Welcome back to the Oncology Brothers podcast. I'm Rohit Gosain. I'm here with my co-host and brother Rahul Gosain. Today, we are focusing on the treatment landscape of pancreatic cancer. And to guide us through the current standard of care, we're joined by Dr. Eileen O'Reilly, a world-renowned medical oncologist and also the section head of hepatobiliary and pancreatic cancer at the Memorial Sloan Kettering Cancer Center. Eileen, thanks so much for being with us today.
Great. Well, thank you both. Pleasure to be here and look forward to our discussion.
Eileen, welcome. Okay, so let's start off with the initial workup for a newly diagnosed pancreatic cancer patient. What does it really look like in your clinic? And can you also touch on the importance of germline testing here?
Yeah, thanks. So this is an important practical question for a person who comes in the door. We're suspecting this diagnosis. We want to get optimal imaging, so CT pancreas angiogram, which allows fine cuts through the pancreas with contrast, including chest and pelvis. That will cover the imaging. And from the lab perspective, just getting regular labs in terms of CBC, comprehensive panel, getting a CEA, CA99, and importantly, glucose, right? Well, for a lot of these individuals, we'll see that there's been some prodrome in terms of elevated HbA1c and or glucose. So understanding that and being mindful of that. And for anybody whom we're suspecting anything pancreas related, we will want to get comprehensive genetic testing. As you pointed out, getting germline testing using ideally a panel, which will cover BRCA1, BRCA2, Lynch genes, ATM, PALB2, and some of the other core genes, and tumor-based somatic testing. And these days, often complemented because of the tissue acquisition challenges of utilizing ctDNA. It's not a perfect tool, but it can be very helpful in these days where we now want this information as early as we can, as we're thinking about hopefully more targeted treatments integrated into first-line decision making.
Thank you for covering that, Eileen. Well, we don't have good screening tools for pancreatic cancer in general. As a result, when we diagnose them in locally advanced or rather metastatic stages. But before we dive into that world, let's go over to our early stage where we do get lucky and do diagnose them at an earlier stage. What does your treatment paradigm looks like, especially from adjuvant therapy standpoint?
Yeah, so for a person with resected pancreas cancer, so they've been able to undergo surgery and have no visible evidence of disease, international standards of care guidelines would support multi-agent chemotherapy, and for a fit individual, that's modified FOLFIRINOX. And a couple of things about the modified version of FOLFIRINOX in the adjuvant setting is just being mindful of the dose of irinotecan. We do see more diarrhea in this patient population, possibly related to the surgery, and absenting any, specific UGT 101 consideration or the very rare DPD consideration. But even there, just to always be conscious of that, and no bolus 5-FU in the adjuvant setting. The things that I think about when weighing up what's the right time to start is to ensure that somebody's wound has, healed. So that's obviously straightforward. But to make sure that they have adequate nutrition, that's really key. This is a stiff regimen at the best of times, and when a person is not eating and hydrating well, it's a setup for trouble and early hospitalization. So ideally, they're maintaining their weight and even starting to gain weight in the post-op setting. And in parallel with that, right, that they have a level of functional recovery in terms of day-to-day activities. So I think all of those three things are the milestones that we look for to make sure that a person is going to, to tolerate adjuvant therapy.
Eileen, thank you so much for laying that foundation. You touched on this, no 5-FU bolus. Is that the case throughout the paradigm where you're not using any 5-FU bolus given the data does not really support and then use a flucovorin?
Yeah, good questions. I think no real consensus on this, but many of the adopted versions of modified FOLFIRINOX in the metastatic setting do not use bolus 5-FU. And if you don't give bolus 5-FU, right, what's the value of leucovorin? It's really modulating the bolus. And I can't say we're always consistent in that. And, you see that through some of the other regimens, but that I think is a very real approach. Our version of modified FOLFIRINOX is dose adjustment of all components as opposed to singling out individual ones. And if you look at the original phase 3, the median dose intensity over time was about 80%. So that's very reassuring.
And again, for our community listeners, this has been the case where 5-FU bolus is not compromising any outcomes. It tends to increase more side effects. So throughout the GI paradigm, we've seen that omitting 5-FU bolus is actually safe. Coming back
Yeah.
here, when it's borderline resectable disease, we do have a few options, and this can start to get complicated very quickly. How do you decide which treatment? How you're deciding the number of cycles? Is that dictated by the overall response? Is it by our surgical colleagues? Any role of radiation here? Can you walk us through this space before we switch gears to metastatic disease?
Yeah, so thank you for this. This is, again, an important practical day-to-day question, right? What are the best strategies for management of locally advanced pancreas cancer? And I think one key point is the multidisciplinary approach. We like to have our surgery colleagues in close collaboration and often our radiation colleagues too, and have a consensus paradigm in terms of how we approach this group of people. And remembering that this is a spectrum, right, from locally advanced, which can include to complete vascular encasement, as in arterial encasement, where there's very unlikely to be any local operative potential, to the group of people that have maybe a fairly high chance of going to surgery, 65% in the more borderline resectable approach. And this can be very, very nuanced with more potential for operation in the setting of venous vascular involvement as opposed to extensive arterial involvement. So with that, I think first and foremost is the functional status of the individual and their nutrition. So they're more general themes as we drill down to the individual treatment regimens. We've choices, as you were alluding to, with modified FOLFIRINOX and gemcitabine-nab-paclitaxel and potentially NALIRIFOX too these days, although data there is in the metastatic space. So, mostly for fit younger individuals, it'll be using modified FOLFIRINOX. That's where we have the bulk of the data, but it's a very reasonable approach to use gemcitabine-nab-paclitaxel and dose-adjusted strategy, 2 weeks on, a week off, or even every other week in the older, less fit individual. And, patients' preferences are important here, right? The considerations of ports and frequency of infusion visits and considerations of alopecia, all of this factors into what might be an optimal decision. But I think, weight in favor of gemcitabine-nab-paclitaxel in the older and less robust population, and certainly strong weighting in the direction of modified FOLFIRINOX for the younger, fitter group of people.
And I know, as you alluded to, that modified FOLFIRINOX initially, at least in young fit patients, but sometimes we do see that they won't even respond to modified FOLFIRINOX, where CA19-9 won't budge too much, and on repeat imaging, at least the scans are not showing progression. Do you usually change your course to gemcitabine-nab-paclitaxel and then see the responsiveness based on that?
Yeah, I think this is another very important point, is when should we make that decision to potentially adjust treatment? And a couple of things that I keep in mind as I think about this is at the beginning, at the time of diagnosis, right, this disease can often be biologically very active. It's making people very sick and appetite down, pain down, sugars haywire, etc. it can take some time to just get the cancer under control and get things stabilized. And we all want it to be better yesterday, of course, most of all the person and their family. But it does take some time. So I'm always a little bit cautious about changing treatment quickly unless it's truly very clear that it's not working. So we use all the clues, right? And the clinical ones are I think, prime here. If a patient's pain is getting better, that's a very important positive thing. And if they're starting to feel better, and there's nothing subtle about this, when it works, right? We see it. It's very gratifying, and it's evident to all. But it does take typically, sometimes 4 to 6 weeks, 2 to 3 doses of treatment to get in. But if one is reaching the 2-month mark and things haven't changed, and or CA99 is going up, we can't be naive about it, and we certainly have to consider. And increasingly, I think there's comfort with that, and we know biologically too this makes sense, right? There's some tumor types or subtypes that can underpin differential response to treatment. We need to ideally know this up front, and that's another discussion. But I think increasingly there's going to be some selection using these tools to say that this person, apart from their clinical characteristics, is going to be perhaps better suited to receiving X regimen versus Y. We're not quite there yet. Also, just to make note is that the CA99 can go up a bit initially, and especially in the metastatic disease setting when people have a very high burden of disease. It can go up quite significantly over the first month, and just always, advise people just to give it a little time and see. And I would say, often, not always, that will bear out. But yes, I think just careful consideration of all the information at hand, the clinical factors, what the lab trends in terms of tumor marker trajectories, not, individual numbers, but overall trends are telling you. And of course, imaging. Just keeping in mind that imaging can lag a bit, especially at that first assessment point for the locally advanced and even in the metastatic setting.
Eileen, thank you so much for covering that. Now, an important question that is rather the more common entity, unfortunately, which is the metastatic pancreatic cancer, where in fact the median overall survival is just about a year time. Can you please walk us through your treatment paradigm here and also answer some of the important questions that would be any role of testing for NGS for somatic mutations outside of clinical trials? And of course, the choice of modified FOLFIRINOX, NALIRIFOX based off of your study, and gemcitabine-nab-paclitaxel treatment options.
Yes, thank you again. So for assessing frontline metastatic disease, I do think comprehensive genetic testing is warranted today, right? As in October 2024, we still are, in the realm, it's a relatively small subset of patients that will identify actionable findings. But I think the field is very hopeful that that is changing with, RAS therapies entering the clinic. So while it's not prime time yet, but going back to the selection of chemotherapy choice, I think the factors are somewhat similar to localized disease, is functional status, nutrition, patient preference, and perhaps this is even both in an academic and a community setting, just how close or not you are to your treating center and the support mechanisms available, because some of these have significant toxicities, and that's important. But typically it's multi-agent cytotoxic therapy as our go-to approach in the metastatic disease, and for fit people, once more, modified FOLFIRINOX. And NALIRIFOX, as you mentioned, is recently FDA approved and guideline endorsed. And often a question comes up, when might one choose that over modified FOLFIRINOX? And I don't think there's a black and white issue, but one that I keep in mind as I think about it is if a person has previously undergone resection and had adjuvant therapy, and then at a later time point, their disease recurs. It makes sense to revisit the regimen. It's been some distance. Maybe a logical consideration is to use a different version of a regimen so that would be one context, and similar paradigm for locally advanced and then later disease progression. We do also have to be mindful that our goals are, for the most part, non-curative here. And again, really important to understand the person, their social supports, and their individual preferences. And some people will say, listen, I hear you, but something that gives me more flexibility, more time with my family, less time in the clinic, and is a milder regimen. That can be a very, of course, legitimate option. And I had a very, kind of heartening discussion on this topic with a young man, and one might have imagined that would be the person that would push the envelope to the nth degree, but very thoughtful, reasons as to why that wasn't going to be the right choice. And so these are, very important, very practical discussions.
Eileen, thank you for touching on that. A common scenario also ends up being a patient that ends up in our clinic with high bilirubin. In that scenario, do you lean towards dose-adjusted gem-nab-paclitaxel? Do you reach out for oxaliplatin in that settings? Because this is not an uncommon scenario in our clinic.
Indeed, it's a very common one, and there are two contexts to this. The one that's the more common is in people who have obstructive jaundice related to tumor or nodal disease at the head of the pancreas or in the porta hepatis, and that's a reversible consideration.
Yes.
So they're thinking about biliary intervention, interventional radiology if it's not accessible endoscopically. But assuming that's a soluble problem, often would start for that individual who's otherwise well with FOLFOX and then scale up with irinotecan and modified FOLFIRINOX. The more challenging and problematic set of circumstances, and it's a very classic picture, usually a left-sided body or tail primary and diffuse liver metastasis. And there it's not so much an obstructive picture, but it's a diffuse disease infiltrative process. That's usually a very concerning set of circumstances, prognostically worrisome, and a much more difficult situation to treat in many regards. That's often a sicker patient population. And there, gemcitabine-nab-paclitaxel, I think one has to go very carefully with because of poor metabolism, heightened toxicity. So usually in that setting, for me, it's always dose-adjusted FOLFOX to start, and then very carefully scale it up if one can get response. One is always hoping in that setting that maybe there's an underlying, BRCA, somatic or germline context that these people will respond, and sometimes they respond very well, but often it's a kind of a spiraling, challenging scenario, that latter context.
Absolutely. And then, unfortunately, we often see this disease progress. So how are you planning your subsequent treatment if the disease has progressed in first line? Can you also touch into PARP inhibitors here?
Thank you. So in the context of disease progression, we'll take that first and then go back to PARP inhibitors. Your nice algorithm here speaks to how we think about it in practice. And in the world of finite choices, it's sort of the opposite to what you didn't have in the front line. So for individuals who've had gemcitabine-based therapy, it's typically 5-FU-based treatments. And usually in that setting, we have an FDA approval for liposomal irinotecan 5-FU, and that's a good choice, or FOLFOX in some people. For individuals who've received modified FOLFIRINOX or NALIRIFOX, typically gemcitabine-based, I usually will try a combination and certainly favor gemcitabine and nab-paclitaxel, but other combinations may be reasonable in individuals where neuropathy is a concern, or comorbidities, or preferences in terms of alopecia, etc. And so there's limited, but some variation on the theme there in the second line setting. So going to PARP inhibitors really don't work very well in the setting of progressive disease, and certainly in the context of platinum progression. So right now they're FDA approved as a maintenance option after platinum-based therapy for a person with germline BRCA1, BRCA2, but we also include people with oncogenic somatic variants and people with germline or somatic PALB2, and maybe a few other rarer variants in terms of the RAD51 genes. They can confer homologous repair deficiency signature. So the best time, I think, to use a PARP inhibitor is when disease is debulked, stabilized, responding, and kind of in a minimal residual disease state in advance of progression. Progression is a very poor surrogate for a favorable outcome with a PARP inhibitor. But PARP inhibitors are a very nice option as an alternative to ongoing cytotoxic therapy for that particular population, and offer again some quality of life benefits. They don't work for everybody, but when they do, we can sometimes get some extended period of time away from chemotherapy, which is very meaningful. And
this is certainly a tough disease to manage. Well, we have covered quite a bit here. Thank you so much, Dr. O'Reilly, for this overview of the current landscape for pancreatic cancer. For our listeners, let us recap with the key points from this talk today. In today's discussion with Dr. Eileen O'Reilly from Memorial Sloan Kettering, we covered the current standard of care treatment for pancreatic cancer. We emphasized the importance of a thorough initial workup, including genetic testing, which can significantly impact the treatment decisions. We discussed the management strategies for resectable, borderline resectable, and metastatic disease, highlighting the role of neoadjuvant therapy, surgical approaches, and importantly, systemic treatment options in this space.
In this discussion, we also had a chance to touch on the emerging role of targeted therapies and the potential of NGS to look for these actionable mutations in pancreatic cancer. The multidisciplinary approach involving case collaboration with surgical and radiation oncology colleagues still remains crucial, especially in optimizing outcomes for our patients with early disease. Thank you so much for joining us, and don't forget to check out our other episodes covering conference highlights, recent approvals, and treatment algorithms. We're the Oncology Brothers.